Hello and welcome to Emergency Medications Every Dentist Should Know. This is going to be part 2. We're going to be talking about atropine, ephedrine, and epinephrine. And I want to welcome you. I am Alan Schwartz, DDS CRNA. As we mentioned in part 1, our main learning objectives for all of these 4 parts are to discuss the routes, stock the medications, become familiar with the medications. We're going to build your emergency kit with common medications that you should have for sedation dentistry, how to use them, when to use them, what their physiology is, and the routes of their administration. And we're still continuing to build the quick and dirty cheat sheet. And remember again about your expiration dates. Make sure that your drugs are all fresh. So in this part, we're going to talk about the sympathetic and parasympathetic autonomic nervous system. We're going to review that, as we will see again and again in some of the further lectures that you'll be having with this entire course. And then we'll talk about when to use atropine, ephedrine, and epinephrine. We're going to talk about the physiology of their use, what they are used for, what they produce in the body as far as any physiological response. We'll talk about their routes of administration, and again, keep building your quick and dirty cheat sheet. We always present the disclaimer to show you that we are not the only source for how you would treat something and how you would work with your patients on this. I refer you to other sources, other journals, books, other lectures about this material. This is the way that I was taught, the way that I perform it in my practice, and I have these same drugs in my emergency kit. As a reminder, here are each of the parts that we'll be talking about. Right now we're at part 2. I wanted you to notice that we did not make a mistake in the way that we wrote the spelling for the words ephedrine and epinephrine in this case. Notice that there are some capital letters there, and there's a bunch of capital letters in a row. This is called tall man lettering, and it was brought about by the Food and Drug Administration back in 2001, and along with the Institute for Safe Medical Practices. It's a way to slow down your reading so that you don't misread the drug. If you look down at the ephedrine and the epinephrine, they can kind of look similar if you're reading very quickly, but they each have very different actions. So it's a way to slow down and really see what the drug is for similar reading and similar sounding drugs. Notice the dissimilarities in their names. Here's some other examples of drugs that are using tall man lettering. I realize that we don't use them necessarily in dentistry, but just know that your patients are using them. So there's glipizide, glyburide, hydrocodone, oxycodone, trazodone, tramadol. You can see each of them. Each of them has a different use, and they have been confused throughout time since the drugs have been introduced for patient use. So make sure that you read very carefully the type and the name of the drug as you go along. So let's review the parasympathetic and the sympathetic nervous systems very briefly. You're going to see this on a number of your other courses, as we said. So they're functioning to regulate the functions of the internal organs throughout the body. It's an automatic system. It's a very powerful system. And the two systems, parasympathetic and sympathetic, counterbalance each other. So let's look at it again now. We've got the parasympathetic side and the sympathetic side. The neurotransmitter for the parasympathetic side is acetylcholine. For the sympathetic side, it's norepinephrine is the neurotransmitter. And again, these systems counterbalance each other. If we have a medication let's say like a vasopressor, it's going to emphasize the sympathetic side. Or if we apply a drug like atropine, it's going to block out, if you will, the receptors on the parasympathetic side. So the sympathetic side is then going to predominate, and we're going to see its effects on the body, the physiological signs. You'll see that predominating in the patient, and that's what we want to do. So here's the anatomy of the parasympathetic nervous system. Notice that there's a number of cranial nerves involved that are on that side: 3, 5, 7, 9, and 10. Notice that the big one, the main one that we're really treating with our medications, are going to be treating the parasympathetic side, cranial nerve number 10. It is known as the vagus nerve, as you remember from school, and it is from the Latin word vagor, which meant to wander, stray, roam, rove, go, and ramble. And if you look at that anatomy again, you can see it wandering and straying throughout a lot of organs and a lot of systems in the thorax and then down into the abdomen. It goes all the way to the bladder and even the sacrum. And its neurotransmitter, as we said, is acetylcholine. The acetylcholine is released in granules. It goes across the neurosynaptic cleft to the axon, the receptors in the axon on the other side of the cleft. So it stimulates a response when those granules are released. And then those granules will then be reuptaken by this presynaptic nerve. If you were to put in several words what the parasympathetic system does, is it just kind of slows your body down so that you're digesting food, you're producing saliva, you're relaxing, your blood pressure's down. It's just kind of a general relaxant type system if you were to look at it that way. So it will cause bradycardia in the heart, slow heartbeat with stimulation. On the sympathetic side, totally different anatomy. You see that there's a chain of sympathetic ganglia along the spinal cord, and that it innervates the same organs that the parasympathetic side does, but it has the exact opposite effects. So we're going to see it speeding the heart, it's going to dilate the bronchi, it's going to go and pretty much turn down the kidney, the stomach, the intestines. It's going to be our fight or flight. We're not going to be slowing down and digesting and salivating as we do with the parasympathetic side. And the neurotransmitter in this case, again, is norepinephrine. And you know that with the word epinephrine there, that's going to cause an increase. Epinephrine itself is adrenaline, which is used for the fight or flight response. So it's going to really speed up the heart, respiration, your breaths per minute, and it's going to really make your eyes dilate so that you can see and run away from the enemy or whatever. So there's the two systems in tandem that counterbalance each other. So the two, again, norepinephrine and acetylcholine, have opposite effects on the heart. And that's going to be the big thing that we're going to be treating with the meds that we have in our emergency kit. And the 3 drugs we're going to be talking about today. You can see the effects of the sympathetic nervous system again on the different organs. So with stimulation, norepinephrine really stimulates the heart into a tachycardia, a rapid heart rate. Let's take a closer look at that neuromuscular junction again. You can see it's quite intimate. So there is a connection from the sympathetic nerve to, let's say, the heart muscle, where there's receptors there along, and there's just millions and millions of nerves along this way. When the impulse comes down the nerve from either the parasympathetic or the sympathetic side, the nerve then will release its granules and be taken up by the receptors, say, at the heart muscle. So you see a picture here of the cholinergic receptors, which are obviously going to be for acetylcholine. So those granules of acetylcholine molecules will stimulate those receptors. And it's the same as with specific adrenergic receptors for the norepinephrine that's released from the nerve terminal. So there are the two side by side. And it's going to have complete opposite effects, as we said, on the heart itself. Those are really rapidly metabolized and they're gone very, very quickly. They're either broken down or they're reuptook into the presynaptic nerve so that those granules can be repackaged and used again. So let's talk about atropine. Atropine is going to block and take up the cholinergic receptors, in this case at the heart where we really want it to work. It'll work on the other viscera too, and it's called an anticholinergic. Remember that the receptors at the heart were cholinergic receptors, and that's from the word acetylcholine. When we block the cholinergic receptors during a bradycardia, it's going to produce a tachycardia because the sympathetic nervous system is going to predominate with its norepinephrine. And we would use that in cases where there's some severe bradycardia, especially on an older patient that needs a constant blood pressure to be able to perfuse all the organs. If someone has a vasovagal response in an emergency, this is the drug that we're going to give the patient to block the vagus nerve and the acetylcholine that's pouring out to make the person faint because of a vasovagal response. And we go into that in a lot more detail in your further lectures. So here's a suggested dose, but I refer you again to the LexiComp paperback book that you can get. It's put out by the American Pharmacy Association, and it is a big, thick book, not very expensive at all, and it really lists the dose and the list of the drugs that not are only in our lectures, but that your patients are taking so that you really deeply understand what these drugs do. Atropine is one of the emergency drugs that we use in ACLS. It's not our primary one, but it's used in pulseless electrical activity. Its route is intravenous or intraosseous. And remember, you might have to use a pressure bag if you're going to squeeze the IV bag to be able to get the fluid and the drug into the bloodstream through the intraosseous route. Let's look at ephedrine. It stimulates adrenergic receptors. So it is a sympathomimetic. It's mimicking some of the effects of norepinephrine. When ephedrine stimulates the adrenergic receptors at the heart, it's going to increase heart rate, which is then going to increase the blood pressure also. So we use it as a vasopressor for a person with a slow heart rate. What we want it to do is to press on the vaso, which means it's going to increase blood pressure, and it also increases heart rate. So it has effect on the blood vessels and on the heart muscle itself. People can develop something called tachyphylaxis with repeated doses at the same appointment for ephedrine. What it does is ephedrine stimulates the release of norepinephrine, and eventually some of those granules at the presynaptic nerve site deplete of norepinephrine, so the ephedrine does not have the same effects as it did originally. This is a little ways down the way after you've dosed it a bunch. You're probably not going to need to do that. But I can tell you from longer cases and repeated use in the operating room, we do see tachyphylaxis, where it just eventually gets to the point where it's not increasing blood pressure and increasing heart rate. So there's times, again, when you're going to want to use ephedrine to raise both of those vital signs, blood pressure and heart rate. And here's the dosages for ephedrine. And its route is, again, intravenous or intraosseous. Let's talk now about epinephrine. Notice that it also has tall man lettering, and it makes it so that you can't confuse it with drugs like ephedrine. So it's going to have the same effects. It's going to stimulate the same receptors as norepinephrine, but adrenergic receptors are very powerful in what they do to the heart and the physiology of the body. So those receptors, in this case along the heart muscle, are going to be stimulated, and it's going to cause tachycardia and then an increase in blood pressure as well as the heart rate because of alpha 1 and beta 1 stimulation. So it's a very pronounced stimulation, and it's very, very quick. Epinephrine is metabolized very, very quickly, but it's going to make a dramatic effect on the heart. That's why we use it in ACLS. It is the lone drug that we use now during a cardiac arrest because of that profound effect. And it's given every 3 to 5 minutes, if you remember, in ACLS. Epinephrine is the hormone that produces the fight or flight response. And it's used to resuscitate patients, as we said, from cardiac arrest. It's also used in acute anaphylactic reactions. It's part of the algorithms that you'll see when you go through other parts of this course. It's used for bronchospasm and bronchial asthma. We've talked about Primatene Mist, and you'll have seen that. It's a racemic epinephrine inhaler that's used to dilate the smooth muscle of the bronchi, and it is just pure nebulized epinephrine. Let's talk about the adrenal gland. You notice that there are more than 30 steroid hormones that are made in the cortex of the adrenal gland. The adrenal gland sits above each of the kidneys. So there's 2 adrenal glands sitting above. So it's adrenal, which is above or at the location of the kidneys. The thing that I want to show you with this slide is not only are corticosteroids made, but also if you look at the medulla, the middle of the adrenal gland, you'll see that catecholamines are made there. And that's where our epinephrine and norepinephrine are synthesized. So let's talk about epinephrine. Notice again that it is one of the major medications used in ACLS. It's used for pulseless arrest, so cardiac arrest, bradycardia, and other algorithms can utilize it too because of its profound effect at the heart. So that, along with defibrillation and all the other things we learn in ACLS, are so very important. It could be used for breathing, it can be used for an allergic response, but for ACLS, you would give the whole vial, which is 1 milligram, which is a lot of epinephrine, and it's rapidly metabolized, but it's used in other places, epinephrine, other than just ACLS. We'll talk about it, and we've talked about it somewhat, that racemic epinephrine is used as an inhaler for someone with bronchospasm. It's used also to stabilize the membranes, bring the heart rate and the blood pressure up in an acute allergic response. We can use it to treat hypotension, but it's not a commonly used drug. We would rather use ephedrine or phenylephrine, depending on the heart rate and the blood pressure. There's such a short half-life for epinephrine that we just don't use it in hypotension. It is given either parenterally, IV, intraosseous, and it can be given through inhalation. I'd just like to show you what catechol is. We've always heard the word catecholamines, so I want to show you it starts with the molecule phenol, which is a benzene ring with an OH group, a hydroxy group on it. So catechol adds another hydroxy group. Catechol itself is a pretty, if you will, toxic agent. It's used for developing black and white film. It's used in pesticides, perfumes. the backbone for vanilla, synthetic vanilla, and synthetic chocolate, and it's used in pharmaceuticals. So you can see with this that what the molecules of epinephrine, norepinephrine, dopamine, and serotonin are. They're all catecholamines. They're going to have that amino group, the NH2 group on them, to make that catechol with an amine. So they're totally related to that. And just to show you with phenol, one of the only molecules that I know in anesthesia that I've got memorized is diisopropyl. You saw phenol at the very top of this diagram, but diisopropyl, so it's going to have 3 carbons and it's in an iso chain, so they're in the middle, they're not just long chains coming off, is the drug propofol. So that's how they got the name for propofol, as diisopropylphenol. Let's look at your quick and dirty drug cheat sheet, and you can see where ephedrine and epinephrine come in, as well as your atropine. Thank you again. We'll see you with the next part of your course.